Most people describe the UK's National Health Service in one sentence: the NHS provides free healthcare. That is true, but incomplete. The NHS is a publicly funded healthcare system built on one major principle: access to essential healthcare should depend mainly on medical need, not personal wealth. But the NHS is also a case study in public policy pressure. It shows what happens when rising demand, limited budgets, workforce shortages, aging populations, political promises, and increasing medical costs collide inside one system. In simple words, the NHS case asks, can a government provide universal health care while keeping it affordable, timely, and high quality? Imagine someone suddenly develops severe chest pain. They should not need to check their bank account before calling an ambulance. They should receive treatment because they need it. This protects millions of people from serious medical bills. But healthcare is never economically free. Hospitals need doctors, nurses, beds, medicines, equipment, technology, ambulances, laboratories, cleaners, and administrators. The NHS is funded mainly through taxation and public spending. This makes it not only a medical organization, but also a political, financial, and administrative institution. The NHS was established in 1948 to provide broad access to healthcare, regardless of income. GPs usually provide the first point of contact. Hospitals handle emergencies, surgery, and specialist treatment. Community services, mental health teams, ambulances, and pharmacies support the wider system. But here's the catch. All these services must work together. If people cannot get GP appointments, they may visit emergency departments. If hospitals cannot discharge patients because social care is unavailable, beds remain occupied. Emergency departments become crowded and ambulances wait longer. An NHS crisis is rarely caused by one department. It usually reflects pressure across the whole health and care system. One of the NHS's greatest strengths is financial protection. Serious illness can destroy household finances in systems where patients pay large bills directly. The NHS spreads that risk across society through taxation. Healthy people contribute. Sick people use more care when needed. This works like social insurance. Another strength is broad access. A low-income worker, unemployed person, child, millionaire, or pensioner can enter the same public system. However, equal access in theory does not always mean equal experience. Waiting times, service quality, transport barriers, language difficulties, and local availability can differ. Wealthier patients may also purchase private care for faster treatment. So universal healthcare does not automatically remove all inequality. One of the biggest pressures is rising demand. The population is growing and aging. People live longer with complex conditions. More patients require long-term treatment for illnesses such as diabetes, dementia, heart disease, and cancer. Mental health awareness has also increased demand. A successful healthcare system may create more future demand because people survive longer. That is not a failure, but it increases pressure on staff and budgets. The workforce is another major challenge. Doctors, nurses, paramedics, therapists, pharmacists, and technicians require years of training. A government cannot suddenly produce thousands of experienced professionals. Staff shortages increase workloads. Heavy workloads create stress and burnout. Burnout pushes workers to leave, placing even more pressure on those who remain. The NHS also depends heavily on international workers. They fill important shortages. But international recruitment cannot replace long-term domestic training and workforce planning. Pay creates another difficult trade-off. If salaries remain too low, recruitment and retention may suffer. If salaries rise significantly, the government must raise taxes, borrow more, or reduce spending elsewhere. There is no cost-free solution. Waiting times are one of the clearest signs of pressure. A patient may technically have access to surgery, diagnostics, or mental health support, but if the wait is too long, the system is not delivering timely care. Waiting lists grow when demand is greater than available capacity. Capacity includes staff, beds, equipment, appointments, buildings, and funding. They cannot usually be solved through one announcement. They require long-term investment, workforce expansion, and better organization. Funding is another major debate. More money can provide staff, equipment, and facilities, but a bigger budget does not automatically produce better outcomes. Money may be wasted through poor procurement, duplicated administration, failed technology, or weak management. At the same time, demanding endless efficiency without enough staff or capacity is unrealistic. The better questions are, how much funding is needed? Where should it be spent? And what results should it produce? Healthcare spending also competes with education, defense, policing, transport, housing, welfare, and debt payments. Almost everyone supports better healthcare. The disagreement begins when governments decide who must pay for it. Social care is closely connected to NHS pressure. An older patient may be medically ready to leave hospital, but unable to live safely without home support or residential care. If social care is unavailable, the patient remains in hospital. That bed cannot be used by someone else. One weakness in social care can create pressure throughout the NHS. Prevention is also important. Many illnesses are influenced by smoking, diet, alcohol, poverty, housing, pollution, and physical inactivity. Vaccination, screening, health education, food regulation, and early intervention can reduce future demand. But prevention is politically difficult. The cost appears today, while the benefits may take years to become visible. The NHS also cannot eliminate health inequality alone. Poor housing, dangerous work, low incomes, stress, and environmental conditions can make people ill. The NHS often treats problems created elsewhere in society. Technology may improve efficiency through digital records, remote monitoring, artificial intelligence, and automated administration. AI may support diagnosis, analyze scans, and reduce repetitive work. But technology is not a substitute for staff, beds, leadership, or good policy. A badly designed process does not become effective simply because it becomes digital. The role of private providers creates another debate. Private companies may supply treatments, technology, construction, or support services. Supporters argue that they can increase capacity and reduce waiting times. Critics argue that profit can remove money from patient care and fragment services. The real question is not simply public versus private. It is whether private involvement provides value, maintains quality, and protects the public interest. Political pressure also makes reform difficult. The NHS is deeply valued by the public. Major changes can create fears of cuts or privatization. Governments may announce short-term funding, new targets, or repeated reorganizations. But structural changes do not automatically solve staff shortages, rising demand, or limited capacity. Politicians think in election cycles. Healthcare planning requires decades. Training doctors, building hospitals, reforming social care, and improving public health all take years. Performance targets can improve accountability, but badly designed targets may distort behavior. Managers may focus on hitting numbers instead of improving the complete patient experience. A serious evaluation should consider quality, safety, waiting times, staff well-being, patient experience, equality, and long-term sustainability. The NHS also faces growing public expectations. Patients want faster diagnosis, advanced treatment, and access to new medicines. These expectations are understandable, but every treatment has a cost. No healthcare system has unlimited money, staff, or time. Every system must decide how limited resources are allocated. This is a form of rationing. It may happen through waiting lists, eligibility rules, clinical priorities, or decisions about which medicines will be funded. The real question is whether these decisions are fair, transparent, and evidence-based. But here's the brutal truth. The NHS is often treated as a political symbol instead of a complex system. Some politicians blame every problem on funding, others blame inefficiency. Some promise technology will solve everything. Others believe another reorganization will fix the crisis. None of these explanations is enough alone. The NHS faces several connected pressures: an aging population, rising demand, staff shortages, long waiting lists, weak social care, health inequality, expensive medical innovation, outdated infrastructure, and limited public finances. There is no single solution. A serious strategy may require more staff training, better retention, stronger prevention, social care reform, modern buildings, improved technology, less duplication, and possibly more public revenue. It also requires honesty about what the system can realistically provide. The NHS can be extremely valuable and seriously under pressure at the same time. Supporting universal healthcare does not mean pretending the system has no weaknesses. Criticizing poor performance does not mean rejecting the NHS principle. So the NHS is not simply a story about free healthcare. It is a case study in universal access, public funding, workforce planning, political pressure, coordination, and difficult trade-offs. At the Learning Studio, we will not study the NHS as either a perfect national treasure or a completely broken system. We will understand it as one of the clearest examples of the pressures facing a modern welfare state. Because the real question is not only, is healthcare free? It is, who pays for it? How quickly can patients receive care? Are there enough staff? How should limited resources be allocated? And can universal healthcare remain sustainable as demand rises?